countries starting in Africa. Before we start, I would like to remind you that we have simultaneous translation for English and French. So please pick your headsets at the back if you need one, because I think you might need one as some of the presentations complete both languages. So we have 5 exciting presenters that will be talking about viral load and linkage, looking at how do we interpret viral load results, impact of peer mentoring on viral load suppression and stigma among adolescents, virological rebound among receptor-exposed patients after failing second-line HIV therapy, prevalence of undetectable viral load in pregnant women in Uganda, as well as monitoring of real-time monitoring of the medication equals virological outcomes among people living with HIV in Tanzania. Without further ado, I'll invite the first speaker, Breton, who is a medical doctor and works in West and Central Africa with SALTES, and will be talking to us about HIV virological failure and how do we interpret those results. Thank you.
Thanks a lot. Merci beaucoup. Okay. Donc, first slide, please.
D'abord, au nom des co-auteurs et du groupe de l'étude opéra, je souhaite remercier les organisateurs d'avoir sélectionné cette présentation dont le sujet est sur la gestion de l'échec virologique, avec ce thème « Donnons la chance aux patients, pas à la première ». Comme vous le savez, l'OMS a introduit en 2015 la recommandation de pratiquer la charge virale pour le suivi des personnes vivant avec le VIH. Et compte tenu, on en a encore discuté ce matin en session plénière, des difficultés d'accès au génotypage, l'idée a été de mettre en place un algorithme assez simple et pour les patients en échec, à savoir défini par une charge virale supérieure à 1000 copies, il est proposé d'évaluer l'observance et de contrôler une charge virale 3 à 6 mois plus tard. Et si cette charge virale est toujours supérieure à 1000 copies, de passer en seconde. On a une récente méta-analyse qui montre que cette stratégie de renforcement de l'observance permet d'obtenir une suppression virologique dans pratiquement la moitié des cas, permettant d'éviter des passages trop rapides en seconde ligne. Ce qu'on sait aussi, c'est que dans la vraie vie, sur le terrain, l'utilisation de la charge virale reste difficile. Vous avez là cette représentation d'un travail publié cet été sur la prise en charge de l'échec virologique en zone rurale ou les autos, qui montre que vous avez moins de la moitié des patients qui ont une charge virale supérieure à 1000 qui vont bénéficier d'une charge virale de contrôle et le passage en seconde ligne est beaucoup plus faible. Donc globalement sur la même méta-analyse, avec principalement des patients qui viennent des études principalement d'Afrique du Sud, on estime que le taux de passage en seconde ligne est aux alentours de 50%, mais donc beaucoup plus faible dans certaines régions. Dans le cadre du projet Opéra, le projet Opéra était un projet permettant l'accès à la charge virale qui a été développé dans 4 pays d'Afrique de l'Ouest et du Centre, en Côte d'Ivoire, au Cameroun, au Burundi et en Guinée. Ce projet qui a duré 6 ans est basé sur l'implémentation de plateformes ouvertes et polyvalentes permettant un accès, on imaginait, facilité à la charge virale. Les machines ont été installées dans plus de 13 centres, il y a environ 300 professionnels de santé qui ont été formés. Et dans la durée de ce projet, il y a environ 230 000 charges virales qui ont été réalisées. Ce que vous voyez là dans les différents pays et au global, c'est qu'en cas d'échec virologique, c'est des patients qui sont en colonne verte. Vous voyez que le contrôle, c'est en jaune et faible. En gros, 12% des patients qui étaient en échec virologique ont bénéficié d'un contrôle, comme recommandé dans un délai de 3 à 6 mois. Et c'est beaucoup plus compliqué pour voir les patients qui ont été switchés. J'ai mis une petite loupe pour aider. Ça reste absolument infime. Donc la majorité des patients qui étaient en échec n'ont pas bénéficié d'un passage en seconde ligne. Donc pour la présente étude, notre objectif a été d'étudier les raisons pour lesquelles les prescripteurs d'antirétroviraux avaient des difficultés à passer les patients en seconde ligne. Et donc on a fait un travail mix qualitatif et quantitatif dans le courant du printemps de l'année 2019 dans les 4 pays, avec des études, avec des données quantitatives en interrogeant des prescripteurs d'antirétroviraux et des données qualitatives qui ont été recueillies pendant les focus group et des séances d'information. Donc ça, c'est les caractéristiques des personnes qui ont participé. Donc vous voyez qu'on a majoritairement des personnes qui sont avec un diplôme médical à plus de 90%, c'est logique avec le public qu'on disait, avec des prescripteurs d'antirétroviraux dans ces régions, et des gens qui ont une expérience relativement prolongée, en gros 6 ans d'expérience de prise en charge de personnes vivant avec le VIH. En termes de connaissances, donc ce qu'on voit, c'est que les connaissances en termes de CD4 et charge virale, connaissances sur les guidelines de seconde ligne, la prescription des secondes lignes, il y a globalement une assez bonne connaissance pour la majorité des participants. Par contre, l'interprétation de l'algorithme, en particulier le respect du seuil à 1000 copies, ou le respect des délais, ou l'interprétation du délai de 3 à 6 mois est beaucoup plus difficilement compris. Donc c'est assez significatif la différence entre la connaissance et l'interprétation. Ce qu'on voit aussi quand on interroge, donc ça c'est les points de vue des prescripteurs sur les difficultés, les obstacles à l'utilisation de la seconde ligne. On voit que c'est surtout les causes institutionnelles et organisationnelles qui sont représentées. Au premier lieu, donc, la charge de travail augmentée et le délai pour avoir le résultat de la charge virale qui est jugé trop long et qui est une cause associée à 80% des prescripteurs. Assez logiquement, comme on demande aux prescripteurs leur avis sur leur propre pratique, les raisons individuelles sont évidemment beaucoup moins représentées. Juste un petit mot, c'est une autre étude mais que je vous présente là, un travail qui a été fait au centre associatif ARSS au Burke, qui est un centre d'excellence qui travaille depuis plus de 30 ans dans la prise en charge des patients vivant avec le VIH. Et donc, on va dire des conditions quasi parfaites, puisque dans ce centre, les patients ont un accès régulier à la charge virale, le délai de rendu moyen du test de charge virale est 12 jours, l'accès à la seconde ligne est disponible. Et ce qu'on voit dans ce site, c'est qu'il n'y a finalement que 38% des patients en échec sur cette petite cohorte de 30 patients sur l'année 2018 en échec. Il n'y a que 38% des patients qui ont été passés en seconde ligne, avec un délai prolongé, un délai médian aux alentours de 500 jours. Et de façon intéressante, on voit que le seul facteur associé au passage aux secondes lignes, c'est le fait d'avoir des charges virales très élevées. Et donc ça va bien dans le sens de ce qu'on a vu, c'est quand la charge virale est proche du seuil, on a du mal à passer les patients en seconde ligne. On va passer maintenant aux données donc qualitatives. Donc la première chose sur finalement comment sont perçues les secondes lignes. Un élément important, c'est que c'est aussi bien les gestionnaires de programmes VIH que les prescripteurs sont tous convaincus que les secondes lignes sont une ressource rare et précieuse. Et en particulier pour les gestionnaires de programmes VIH, ils sont face à un dilemme. Faut-il acheter des secondes lignes qui coûtent 3 à 5 fois plus cher que les premières lignes pour traiter les patients qui en ont besoin? Et dans le même temps, il faut aussi acheter de plus en plus de premières lignes de façon à permettre de mettre en place la stratégie du traitement pour tous. Et donc, dans un contexte international de baisse des financements, ça reste effectivement un challenge un petit peu difficile. Et ça les pousse à globalement vouloir limiter et contrôler la prescription des secondes lignes avec des messages tels que donner la chance à la première ligne pour éviter justement la surprescription. Du côté des prescripteurs, ce message est parfaitement bien reçu et effectivement, les messages qu'on entend, c'est on nous a demandé d'être prudents, nous devons préserver la première ligne, nous devons nous justifier, être capables de nous justifier si on passe un patient en seconde ligne. Et de façon plus générale, quand on interroge les prescripteurs sur les représentations qu'ils ont de la seconde ligne, on voit que les représentations sont en fait assez négatives. Les mots qui spontanément sont la sanction, l'échec, la peur, la responsabilité. Et plus encore, quand on les interroge sur la représentation qu'ils ont des patients en échec, on se rend compte que pour beaucoup d'entre eux, les représentations sont très négatives. Les patients en échec virologique sont considérés comme des patients qui ne sont pas sérieux, des patients qui sont des menteurs, des patients qui sont des délinquants. Concernant le renforcement de l'observance, on se rend compte que c'est quelque chose d'assez compliqué. La première chose qui est vraiment importante, c'est que le renforcement de l'observance est considéré comme quelque chose de critique et d'essentiel à obtenir avant de passer un patient en seconde ligne. Il faut que tu sois certain que l'observance est bonne pour passer un patient en seconde ligne. Cependant, on se rend compte que le counseling de l'observance ainsi l'annoncement des résultats de la charge virale et de l'échec reste quelque chose d'assez difficile et souvent c'est très injonctif, voire dramatisant. Donc on a des propos sur un patient en échec, c'est tu dois faire un effort, tu dois mieux prendre ton traitement, sinon tu vas tomber malade. Et de façon plus dramatique, c'est si tu ne fais pas un effort, c'est ta dernière chance et après tu vas mourir. Sur la compréhension des mécanismes de l'échec, c'est quelque chose qui est finalement assez peu évalué. Et on a plus tendance à considérer que l'échec est lié à quelque chose qui vient du patient, c'est de la faute du patient, c'est le patient qui prend mal son traitement. Et on considère que c'est parce que c'est un menteur ou parce qu'il n'a pas compris, mais on n'analyse pas trop les autres causes d'échec. Et enfin, pour les prescripteurs, c'est très compliqué d'avoir une évaluation de l'observance, d'autant plus que la représentation des patients en échec est assez négative. Donc finalement, quand on cherche la meilleure façon de mesurer de façon objective l'observance, on se rend compte que c'est beaucoup la charge virale qui est utilisée. C'est bien évidemment une situation compliquée parce qu'un patient en échec virologique aura une charge virale élevée, il sera considéré comme inobservant. Et donc on aura plus de difficultés à le passer en second. Quand on vient à l'interprétation de l'algorithme, comme je disais tout à l'heure, l'algorithme est parfaitement connu par la majorité des prescripteurs qui ont participé à ces entretiens. La difficulté, c'est le respect du seuil à 1000 copies, même si ce seuil est bien connu. Dans la situation, on a un patient qui a une charge virale qui a baissé sur le contrôle, même baissé de façon modeste, non significative. En fait, on va avoir des propos comme « ça baisse, c'est bien, il faut continuer les efforts, on va atteindre le seuil ». Et donc ça conduit à avoir de plus en plus d'interventions pour renforcer l'observance, mais pas à changer. Et si par contre on a la charge virale qui monte, on va dire là on n'a pas été assez efficace, il faut faire le renforcement, il faut insister, et donc finalement, quel que soit le résultat, on va faire et refaire des renforcements de l'observance. Concernant le délai de 3 à 6 mois, on se retrouve parfois dans des situations où les prescripteurs ne sont pas à l'aise avec l'algorithme et avec des interprétations comme si mon patient a eu un prélèvement au mois de janvier et que j'ai le résultat au mois de mars, à partir de quand je le prends. Et donc on sait dans le contexte que les délais de rendu de résultats, les délais de rendez-vous de patient, le délai pour refaire un prélèvement fait que très souvent on ne respecte pas ce délai de 6 mois, c'est souvent plus long. Et donc un certain nombre de personnes se disent comme ça ne respecte pas l'algorithme, le résultat n'est pas valable et il faut recommencer. Et donc finalement on se retrouve dans une situation où à partir de cet algorithme de l'OMS qui est relativement simple, on a peut-être en fait dans la vraie vie, désolé d'avoir détourné le logo de l'OMS, quelque chose d'un peu différent. Premier point, c'est que la traduction de l'algorithme de l'OMS sur Evaluate for Alliance Concern, c'est devenu renforcer l'observance. Ce qui n'est pas tout à fait la même chose et qui fait que peut-être que l'évaluation des difficultés d'observance sont peu présentes. Mais surtout, ce qui se passe, c'est quand on a un patient qui a une charge virale contrôlée plus de 6 mois après, on considère que c'est pas valable. Si on a une charge virale qui baisse mais qui reste supérieure à 1000, c'est un succès du renforcement de l'observance en continu. Et on renforce l'observance. Et si ça augmente, c'est un échec qu'il faut encore renforcer. Et finalement, quasiment dans tous les cas, on ne passe pas les patients en seconde ligne et on donne cette fameuse chance à la première ligne d'être efficace. Et on a beaucoup de mal à changer le traitement. En conclusion, il y a évidemment des limites dans ce travail. C'est un travail sans entretien individuel, sans études échographiques, on pourrait préciser ces données, et qui en plus n'a évalué que des prescripteurs antirétroviraux, donc il n'a pas étudié ces autres personnes qui sont responsables de la prise en charge, en particulier du renforcement de l'observance. Ce qui est intéressant, c'est de voir que les principaux critères qui sont associés pour les prescripteurs sont des difficultés sur le délai de rendu de résultat et sur les problèmes de gestion de ressources humaines et accessoirement d'accès aux secondes et troisième lignes. Si on a cet élément important qui est la difficulté des programmes nationaux d'arriver à faire ce choix entre les secondes lignes et les premières lignes, avec sans doute un intérêt d'améliorer la quantification des besoins de seconde ligne, d'avoir une meilleure communication entre les programmes et les prescripteurs. Concernant les prescripteurs, donc, ce qui ressort de ce travail, c'est que les prescripteurs ont une très bonne connaissance théorique, mais par contre, c'est beaucoup plus compliqué l'application pratique de ces algorithmes. Et on voit aussi la difficulté des prescripteurs à annoncer l'échec, à renforcer l'observance, qui reste un enjeu tout à fait majeur. Donc, dans le cadre du projet, on a développé un guide de l'annonce de l'échec et de l'accompagnement des patients pour essayer justement de rendre plus pratique avec des phrases. C'est un travail qui a été fait de façon collective avec des soignants, des responsables de programme et et des associatifs des 4 pays du projet du Sénégal. Et puis on a aussi développé des modules pratiques pour effectivement favoriser la formation et l'utilisation des résultats de charge virale. Tous ces modules sont disponibles et téléchargeables en version française ou en version anglaise avec le lien qui est. Merci de votre attention.
Merci, Breton. Thank you so much. I think it brings out important dimensions and attitudes of healthcare providers towards prescribing second-line medication and some of the challenges that we're facing. I would ask that you reserve your questions towards after all the 5 presenters have gone through their presentations. I would like to call up Burke, Virginia, who is with the Johns Hopkins Bloomberg School of Public Health, but he's going to present work that was done in Ndola, Zambia, Project Yes, which engaged peer mentors, and she'll tell us more about those results.
Good morning, everyone. As I was introduced, my name is Virginia Burke. I'm a research associate at the Johns Hopkins Bloomberg School of Public Health in the United States. And I'm here today to represent Project Yes, Youth Engaging Towards Success, and present the results of our randomized controlled trial, the impact of peer mentoring on viral suppression and internalized stigma among HIV-positive adolescents and young adults in Ndola, Zambia. So as we're all now well aware, adolescents and young adults have been identified as a key population for reaching the 90-90-90 goals worldwide. And in Zambia, 15 to 24-year-olds have much lower rates of viral suppression compared to populations in other age groups. There's now been a global call to involve more youth in solutions to address this situation, and so in response, we developed the Project Yes program. So Project Yes had 2 study objectives. The first was to test a peer mentoring intervention to improve HIV-related health outcomes, including viral suppression and internalized stigma, among youth as they transition to self-management and adult care. And our second objective was a qualitative aim to examine experiences of youth, families, and healthcare providers with this peer mentoring program. So today I'll be presenting results from our first study objective. Our second study objective has been presented previously in this conference this week, and some of those data are still being analyzed. So the methods of our randomized controlled trial, we conducted the trial in 4 clinics in Ndola, 1 children's hospital, which was our pediatric clinical setting, 1 adult hospital, and 2 primary care facilities, which were our adult clinical settings. We also trained and paid adolescents and young adults living with HIV who are slightly older than our study population as peer mentors, and consecutively recruited youth and randomly assigned them to intervention and control arms, and the intervention participants then attended a 6-month intervention. We collected both baseline and follow-up data, which consisted of a mobile tablet-based survey as well as a viral load test. So our intervention was composed of several elements. In terms of the activities for our youth participants, we had an orientation meeting for each participant in which he or she met with the healthcare provider at their clinic, their assigned youth peer mentor, and a caregiver if they chose to invite one. Then following that, they had one-on-one monthly meetings with their assigned peer mentor, as well as the option to attend monthly youth group meetings with other youth at their clinic that were participating in the program, and those were also facilitated by our peer mentors. In complement to that, we had 1 activity for caregivers of these youth participants, so we had 5 monthly caregiver support group meetings as well. In terms of analysis to test our impact of the randomized controlled trial, we used generalized estimating equation models adjusted for age, sex, and clinic, and evaluated the effect of study arm over time on viral suppression and internalized stigma. For the purposes of our analysis, we define viral suppression as being less than 1,000 copies per milliliter. And we defined internalized stigma using a Gleichman scale of 3 questions that measured feelings of worthlessness, shame, and guilt due to living with HIV. And I'll go into more detail about that measure as we go through the results. So we analyzed data for 273 of our youth participants, the majority of whom were female, 15 to 19 years of age, self-reported that they had been perinatally infected, had completed primary school at the time of enrollment, and 44% were receiving care in a pediatric clinic setting. So we had quite high uptake of our intervention, which we were pleased to see. Among our intervention participants, 95% attended an orientation meeting, and 74% attended at least 5 of the 6 offered one-on-one meetings with their peer mentor. The uptake of the group meetings was slightly lower. 45% attended at least 5 of the 6 youth group meetings, and about 47% had a caregiver attend at least one project-based activity. And what we take from this is high feasibility and acceptability for the peer mentoring model, particularly for the one-on-one meetings with the youth peer mentors. And through some of our preliminary findings from our qualitative in-depth interviews, we're seeing that some of the lower attendance for group meetings may be due to scheduling challenges. Of course, one-on-one meetings have a little bit more flexibility to arrange based on independent schedules, whereas the group meetings were typically held on Saturday mornings and afternoons, and some youth were unavailable to attend those. All right, so the first result I'll present is the impact on viral suppression. So as you can see from these graphs, and I hope you can see from all the way in the back, we actually saw an increase in both study arms, however, no relative change between study arms. This is across all 4 of our clinics, comparing intervention and comparison, both at baseline and then at follow-up after the intervention. So there are a few reasons we think this might have been the case. We think it's possible that by the nature of participating in a research study, we were calling them for data collection. Perhaps they were aware that they were part of a study, and this had some sort of impact on improved engagement in care or adherence. It was also individually randomized, and though we have no evidence of interaction between study groups, it's possible, of course, that occurred. It's also, though, important to note that 16% of our comparison group was lost to follow-up, which is twice as many as was lost in the intervention group. So this could also be influencing some of this finding. So after we looked at all 4 of our study clinics, we stratified our analysis and we looked specifically at our pediatric clinical setting. And actually, when we looked at just the pediatric clinical setting, which is the Children's Hospital, we see a clear impact of Project Yes. So you can see that at baseline, the intervention group has 38% viral load suppression, and by follow-up, they have 70% viral load suppression, whereas the comparison group has remained constant. When we look at the adult clinical settings, we do not see the same change. In fact, we see no significant change in the intervention arm, but a significant change in the comparison arm. And that similarly to when we look at the 4 clinics overall, we believe that this is partially, in fact, due to the fact that we had 20% lost to follow-up in our comparison arm in our adult clinical settings, which is more than twice as much as we lost in our intervention group. Of course, it's possible that some of the folks that we lost to follow-up were failing, and if that was the case, it could be biasing this particular finding. All right, now we'll present our impact on self-stigma, or internalized stigma. So we used the Gleichman scale, which is a 3-question scale, as I mentioned previously, where participants were asked to respond, agree or disagree to the following statements. I feel guilty about living with HIV. I feel ashamed about living with HIV. Or I sometimes feel worthless about living with HIV. And this slide actually shows our prevalence at baseline across both study arms. And you can see that for all 3 of the measures, about 1/3 to 1/2 of participants are responding agree. When we look over time, we were really excited about this result. So after intervention participants have been meeting with youth peer mentors for 6 months, you can see that although intervention and comparison arms started off at about the same rate of self-stigma at baseline, The intervention participants dropped from 50% to 25% experiencing self-stigma after the intervention. So taken together, we feel that these findings suggest that Project Yes is an effective clinic-based approach for engaging both female and male adolescents and young adults living with HIV, particularly due to the improved viral suppression we saw in our pediatric clinical setting and our reduced self-stigma across both pediatric and adult clinical settings. Of course, more research is always needed to evaluate the relationship between internalized stigma and viral suppression over a longer period of time, as well as perhaps to explore the differences between the pediatric and clinical settings and maybe why we saw different rates of follow-up and why the intervention had different effects in these contexts. We attribute any of our positive findings to the work of our youth peer mentors, two of whom are actually here today. We feel this study reflects the potential of all young people to contribute to the effort to end the AIDS epidemic when given sufficient investment and opportunity. Lastly, I'd just like to acknowledge all of the organizations and individuals who made this project possible, with gratitude to USAID, Population Council, and Project SOAR, youth participants, of course, our youth peer mentors, study team, training specialists, research advisory board, and clinic staff. And as I mentioned, we have two of our youth peer mentors here today, so they've offered to answer any questions if anyone would like to talk with them after all the presentations have concluded. Thank you so much.
Thank you, Virginia. Our next presenter is Shumba. He's a medical doctor and a postgraduate student at University of Liverpool in South Africa, and he's going to talk to us about what happens to clients who failed second-line therapy and the follow-up that was done in Johannesburg, South Africa. So Shumba,
Good morning once again. First of all, let me thank the ICASA conference for letting us present our study findings. And also let me also acknowledge my co-authors who are not present with me here. As indicated, I'll be talking to you about findings of the study that we conducted in Johannesburg, South Africa, where we tried to establish the burden of virological rebound among resuppressed patients after failing second-line HIV therapy. So, start with, let me begin by saying that despite efforts of globally scaling up ART therapy, quite a significant number of patients actually experienced treatment failure and required to switch to second-line treatment. And a study conducted by Still actually found that in sub-Saharan Africa, it is estimated that about 0.5 to 3 million are expected to be on second-line treatment as of the year 2020. Of note is that among the patients that are initiated on second line, also a significant number of patients actually experience treatment failure within 6 months. And in South Africa, the typical second-line treatment combination as recommended by WHO is mainly a ritonavir-boosted protease inhibitor-based second-line drug regimen. And of note again is that much as patients are failing this second-line treatment, there's an option of them being switched to second line. But because of the high cost of this third-line treatment, many of the countries are unable to offer third-line treatment. And South Africa is one of the few countries that is able to actually provide limited access to third-line treatment to patients that have actually confirmed drug resistance to second-line therapy. And of note, and of note is that poor adherence is actually one of the key predictors of virological failure in patients on second-line treatment, based on quite a number of studies that have actually identified it as one of the primary predictors, despite there being other factors ranging from viral factors, health system factors, but poor adherence has been highlighted as one of the key predictors. As such, you can see that adherence counseling is actually one of the key interventions that is provided to patients that fail second-line treatment. And we expect that most of these patients would actually achieve the virological suppression as defined by a viral load of less than 400 copies per mil. And once these patients have achieved the virological suppression, we also continue to provide enhanced adherence counseling so that we maintain this state. However, a significant number of patients also tend to experience subsequent virological failure, which is defined as virological rebound. But this actual burden is not known, and also we don't know the optimal number of adherence counseling sessions that these patients ought to receive in order for them to maintain a virological resuppressed state. So, based on some studies that have been conducted, that have shown that there are high proportions of patients that are actually experiencing virological rebound. And one of the studies was conducted in South Africa, which found that about 19% of the patients that had resuppressed actually had experienced virological rebound. Likewise, in Eswatini, where they found that about 51% of the patients had experienced this virological rebound. So, with that being said, knowing that this burden hasn't been well documented, we conducted a study to try and estimate the incidence rates and also investigate predictors of virological rebound. Our study was actually a retrospective cohort study where we used routinely collected patient data, which is captured on therapy HIV, which is an electronic medical record system. And our study site was Tebaletu Clinic, which is based in Johannesburg, and this is one of the largest HIV treatment sites in South Africa. And our study participants were adult patients aged at least 18 years who were virologically resuppressed and had actually achieved this virological resuppression within 12 months after they had they had experienced their first second-line treatment failure. And we actually looked at patients that were part of this Tebaletu clinic cohort from the year 2012 to 2016. However, we did not include patients who were pregnant and also patients who had exited the cohort within 3 months. And the map there is just showing the location of Tebaletu Clinic. Our study baseline was actually defined as the time when these patients had achieved the virological resuppression. And we followed these patients for about 24 months. And censoring was actually done at the time of loss to follow-up, death, when these patients were transferred out to another treatment site, and if they had changed to an PI-based regimen. And we actually ended our censoring at the end of the follow-up period, which was 24 months. We defined our outcome, which is virological rebound, and this was a binary variable. We defined it as having a viral load that was at least 1,000 copies, at least 3 months from baseline. This was done because we wanted to exclude any of the patients that had experienced some viral blips. We also considered 2 consecutive viral loads that were between 400 to 900 copies, so long as they were 3 months apart, as also a virological rebound. Our exposure variables were social demographic and clinical characteristics, and our analysis, which was both descriptive and inferential, was conducted. And in the inferential analysis, we actually modeled a Cox proportional hazard regression model, and our analysis was conducted using Stigma. In terms of our study findings, we had 242 patients that were included in the analysis, and they had contributed about 3,676 person months. And the restricted mean survival time was 19.7 months. And we also found that about 71 of the 242 patients had experienced virological rebound, representing a prevalence of 29.3. And the incidence rate, which was our primary objective, was found to be 23.2 per 1,000 person years, which is quite high. And when we look at the baseline characteristics, you will see that we had about 57% of our clients that were female, and then the median age was about 41 years, with the minimum being 18 and the highest being 73, sorry. And we had about 33% of the patients who had a normal BMI, and about 57.4% of the patients did not have a CD4 count at baseline because it was not indicated or it wasn't measured. But we had a significant number of patients, about 29%, who had a CD4 count that was less than 500 cells per microliter. The viral load at baseline, which was below 400 copies per mil, you can note that about 76% of our clients had actually a viral load that was less than 200 copies. And again, at baseline, we had about 42.9% of our patients or participants who were on an NCT lamivudine lopinavir drug regimen, and we also had about 79% of patients that were adherent based on the self-reported adherence measure, where we tried to look at the pill count. And we had about 63% of the participants who were on ART for more than 3 years. About 92% did not have any TB co-infection history. And during follow-up, we had about 49% who had received about more than 5 enhanced adherence counseling sessions. And about 5.7% had experienced ART interruption during the follow-up, and about 24% had actually experienced some adverse drug reactions. Looking at the survival, you can see that there was no statistical difference in the survival of these patients in terms of their probability of surviving a virological rebound in terms of sex. So males and females did not have any significant difference in terms of survival. However, we looked at the number of adherence counseling sessions that these patients had. We noted that those that had received more than 5 adherence counseling sessions were actually less likely to experience virological rebound, as seen in the survival curve, Kaplan survival curve on my far left. In terms of the model, as I indicated, we had modeled a Paso regression, hazard regression model. And of note was that in the adjusted model, we found that patients that were actually underweight, having a BMI of less than 18.5 kilograms per meter squared, were actually more likely to experience virological rebound. with a hazard ratio of about 3. And we also found that patients that had a low CD4 count at baseline also had a very high risk of experiencing virological rebound. And lastly, we found that about 89% of the hazards were lower for patients who had experienced, who had actually received more than 5 enhanced adherence counseling sessions, meaning that patients who received more adherence counseling sessions were less likely to actually experience virological rebound. Well, our study also had some limitations, and one of the biggest limitations was missing data. And because of that, we were unable to include some of our covariates in the final analysis. We also had a significant number of patients that were lost to follow-up or had exited the cohort during the follow-up period. So this being said, might have actually underestimated the actual incident that has been reported. And again, the fact that we excluded some patients that had experienced some high viral loads within 3 months from the follow-up period, that might have also introduced some survival bias, meaning that the group that we analyzed were much healthier as compared to the one that we had excluded. And again, looking at the definition that we used, it was also possible that we might have misclassified some of our cases as virological rebound cases, knowing that some of them might have been some viral blips. And another limitation is that this study did not look at drug resistance. So this needs to be investigated probably in further studies. And in terms of generalizability of these findings, I think these findings may actually be generalized to a population that has got similar patient characteristics and health system characteristics, knowing that Prevalence clinic actually offers more comprehensive HIV management services. So therefore, the external validity might be questionable. In terms of the strengths of this study, this is the first study to actually investigate virological rebound burden, and we actually had a substantially larger sample size as compared to studies that have also looked at virological rebound, and also studies that have been actually looking at the initial failure in second-line treatment. And this study also had a longer duration of follow-up as compared to other studies. And lastly, we actually used routinely collected clinical data, which actually gives a true reflection of HIV treatment management on the ground. To conclude, you might note that the finding says that the incidence rate of virological rebound was quite high. And because of this, there is a need for us to actually enhance patient-centered interventions that promote more frequent and intensive ART monitoring through viral load monitoring. But also, there is a need to champion interventions that champion improved ART adherence, and also interventions that try to improve immune recovery and also normalize the body mass index in these patients, knowing that these elements have been identified as key predictors of virological rebound. And there's a need for further studies to be conducted where they would also look at other covariates which we did not include in our analysis. But also, more importantly, it is very important for studies to also look at drug resistance in these patients. With that being said, I would like to acknowledge the study participants, but also let me acknowledge the funders of this study, USIP and the National Research Foundation in South Africa, and the technical support that we received from Health Economics and Epidemiology Research Office, HERO, and University of Wits, Right to Care, and Gauteng Department of Health, and the staff of TLC. Thank you so much.
Thank you so much. We'll move on to the next presentation. presentation, and Grace Gabagaya, who is a medical doctor and a study coordinator of a study at University John Hopkins group in Kampala, Uganda, and she'll discuss the proportion of pregnant women, HIV-positive pregnant women that were initiated on option B+, and what was the baseline virological status.
Good morning, everyone. Presenting findings from a study that's still going on at Moshi, and we'll be looking at the prevalence of undetectable HIV viral load among women initiating option B+. The two districts of Kampala and Mityana. Presenting on behalf of those co-authors. So the background, we know that ART is recommended for HIV-infected pregnant and lactating women, and once it's initiated, they should continue ART for life. Viral load is key in monitoring adherence to ARVs. The current HIV treatment guidelines in Uganda are such that we are using viral load to monitor treatment adherence and efficacy, and the first viral load is done 6 months after initiation of ART. However, we need to know that if this is done at 6 months, undetectable viral load at initiation can therefore result in overestimation of treatment efficacy and adherence. I'll give you a brief background of the study. This is the Friends for Life Circles for Option B+ study. And our study goal is to improve retention in care and adherence to 2 years postpartum for women that are initiating Option B+ in Uganda. And this is a randomized controlled trial that's composed of 540 HIV-infected pregnant women. Randomized the ratio 1:1, the control arm and the intervention arm. Our intervention is an enhanced peer group strategy, whereas the control arm is the standard of care at the Ministry of Health. So those are the two sites, Mulago, which is in Kampala, and then Mityana Hospital, which is about 74 kilometers northwest of Kampala. So moving further to our study screening and enrollment procedures, the criteria was such that we are enrolling women who are greater than or equal to 18 years of age, who are interested in women who are HIV positive, who are pregnant, and who are initiating ART. So we use self-report to rule out prior exposure to ART. And then we're also interested in where they're residing, and our interest was 20 kilometers within the study sites with intention to remain within that locality. Interested women who are eligible were consented and enrolled into this study. Then prior to enrollment, all the women that consented had confirmatory HIV testing, rapid testing, and for those that were found HIV negative or indeterminate, had DNA PCR testing on the same sample. Additionally, we needed to confirm pregnancy for those that did not have a visible pregnancy, and we went ahead to do urine HCG. At enrollment, we had baseline procedures. We had questionnaires that were administered, Stigma questionnaire, adherence, and the socioeconomic status questionnaire. We also had blood samples drawn for the assessment of baseline plasma viral load. And the instrument that was used to test viral load was the Cobas Amplifred Cobas Statman instrument, whose limit of detection is 20 copies per mil. And the results were reported such that for participants who had 0 copies detected, it was reported as target not detected. And then for those that we had 1 to 20 copies observed per mil, they were reported as less than 20 copies per mil. Participants with target not detected had repeat HIV testing to be sure the participants actually HIV positive. We had repeat antibody testing, and then those that were negative had DNA PCR testing done. So I'll share a summary of the findings of the viral load results for the participants at baseline. You can see our sample size is 532 as opposed to 548 participants were terminated. We had 19 participants with target not detected, which is 3.6%. Then we had 1 to 19 participants we had 10 participants, that is with 1 to 19 copies per mil, which is 1.9%. So we had a total of 5.5% that would term as participants with undetectable viral load. Those are under 20 copies per mil. As a study, we are using the cutoff for 400 copies per mil as viral load suppression. So for viral load suppression at baseline, we had 21.2% of our participants below 400 copies per mil. We went ahead to look at the social demographic characteristics of the different groups. I'll flip over to the next slides because I have these results summarized elsewhere. And so moving on, the mean duration from at initiation to the date the sample was drawn for baseline viral load was 4.4 days. However, we think this does not have so much impact on the result we got for viral load because previous studies have shown that it takes about 5 weeks to 15 weeks for women who have been for pregnant women who have been initiated on ART to move on to undetectable viral load. So 4 days doesn't really impact our result that much. We had a peculiar interest in participants who had target not detected as compared to those that had some copies detected at baseline. So we went ahead to look at the median age in the two groups, and we found that it wasn't, there wasn't any significant statistical difference. So when we move on further to the social demographic characteristics, there was no association between target not detected and the various parameters you see over there. That's the age, gravidity, marital status, religion, as well as disclosure of HIV status to partner. The same with undetectable viral load, and the same with viral load suppression. That's those under 400 copies per mil. However, we found an association between viral load suppression and disclosure to any other person besides partner as well as marital status. So we went ahead to adjust for marital status, and the findings were that those who disclosed to another person were less likely to be virally suppressed compared to those who did not disclose. The odds ratio was 0.64. This made us think that it's possible when participants are virally suppressed, they present with ill health, and disclosure happens in the course of seeking care, the disclosure to other persons. With that, I'll come to the conclusion. We conclude that a small proportion of Ugandan pregnant HIV-positive women initiating ART had undetectable viral load at baseline. We presume this to be light controllers of failed reported ART use, since we were basing on self-report for prior ART use. And then none of the analyzed factors, with the exception of disclosure to any other person besides partner, was associated with baseline undetectable viral load. We, however, need further studies to better understand the biological mechanisms of the light controllers. We also think we need to dig further and have guidelines on how best we can monitor patients that start off with undetectable viral load in terms of adherence and in terms of drug efficacy. Because we know even in spite of the undetectable viral load, there is ongoing inflammation and ongoing immunological loss. So we should be interested about their health. Finally, well, we also need to consider screening for baseline drug levels in self-reporting ART-naive pregnant women with undetectable viral load to identify and disclose ARTUs. I would like to acknowledge our funders, which is NIH, the study team, that's the FLC option B+ study team, and you, as well as our study participants. Thank you.
Thank you so much. Interesting findings. So our next presenter, the presentation actually won the award for the best abstract, track B. So we are honored to invite Kennedy. Kennedy Khumbo is from Kilimanjaro, Tanzania, and is going to talk about real-time monitoring and the association between virological outcomes among people living with HIV in Tanzania. You're welcome.
Okay, my name is Kennedy Khumbo, coming from Kilimanjaro Kilimanjaro Clinical Research Institute, which is located in Kilimanjaro, and I'm also a PhD student at University of Amsterdam Medical Center. So today I'm going to share with you part of our findings, which is we are trying to investigating the use of mobile technology to improve adherence for the people who are living with HIV and their own ART treatment. So this is the preliminary result, and we are going to focus only on the use of real-time medication monitoring, just to see how it has significantly to improve the virological suppression. Yeah, so to start with, we are all aware that for someone to be a good adherence, you have to be on the 95 and above, good intake, just to avoid prevent treatment failure and also to avoid resistance on the drugs. Also, there was a study which conducted in Kilimanjaro trying to see that despite of the large accessibility of the ART, but it was found that majority, they still have a problem to adhere to the medication. Actually, the study was found that less than 70% of people could not able to reach 95 and above adherence. And there was several factors which influenced that. One was the patient-related disease and also the health system. So the study recommended that there's a need of trying to explore more on the intervention, specifically on the people who are living in the rural area, on how they can be able to have better access to able to improve their adherence. So in Tanzania, for instance, 80% of the people who are adult, they have access to the mobile phone, and 60% they are just a normal phone, the one which does not have the internet. I mean, not the smartphone. And still, SMS is the major way of people to communicate. And we have advantage of having several service providers which contribute to the cheaper services when it comes to the issue of the communication. So the aim of this study exactly was trying to see that if the reminder would have the impact, especially for those people who have so much problem on the forgetting on the taking their medication, and the report also, which is the real-time report, would have been influenced better feedback during the clinic session. So the study was conducted in Kilimanjaro, which is a border to Kenya. So we only focus on the two centers which are located in Kilimanjaro, KSMC and Majengo. We did the randomization. It was equal randomization, which is 1:1:1. We have RTM, which I can explain later, and we have SMS reminder and the control. So we follow the participant for 12 months, and the outcome was to compare before the intervention and after the intervention. Basically, we still focus on the standard of care, which they are, the treatment measures, which are based on the standard of care, which are self-report, pharmacy refill count, and viral measures. So when we randomize these participants, so for those who will fall under RTMM arm, I'll come to show it later, that's why I highlighted it. But for those who went for the SMS arm, so we sent a reminder SMS half an hour before their time of intake, and later we sent another messages which came 1 hour after the time of the intake. Mainly was just to follow up to see that if they took the medication. And the message was simply that did you take your medication. The reminder was simply that don't forget to take your medication. And 1 hour later we sent a follow-up question which was did you take your medication? And the question was followed with keywords which they have to respond like yes or no. So we count the keyword as the good adherence, or if they don't respond with it like, okay, so this person was not taking the medication. And later, for those who follow under standard of care, they still continue with the standard of care. So this is how the device, the RTMM works. So we call it a real-time medication monitoring because, so the device is the way, it's look like, I don't know if we expect to demonstrate it today, but we didn't bring it. But the device, it's look like a glasses cases, so it's very small device, portable, and it uses the technology like mobile phone. So it has the SIM card inside, which sends the signal to our server once the device is open. We have the interface, which you can see here, and when we log in, we can create so it's based. So if your time of intake is let's say 8 p.m., so we set the time 8 p.m. and the device has to be open within that range of the time. If it did not open, the participant will receive an SMS that please don't take your medication today. So we thought that would have, so the SMS was part of the device that could have a trigger that the person to take the medication. So this is how the platform is to look like. So you can see it has battery status. You can see the batteries, because you need to charge the device as well. Mostly the device, it can stay with the power for more than 3 up to 6 months, depending where the network coverage you are. You can see the status, we can see the status, and if the device is about to finish, we normally inform the participant that you need to charge the device. We can also see the time when the device was last open, or when the device was, if the device was like live but it did not open, we can able to see that, because some of the participants, they trained not to open the device. That's why we're able to create a report. And later, so this is the report we get from our device, from our platform. So the report is tailor-made, meaning like each device produces its own report. And if it's opening on time, you can see this is the bar, show that the device was open on time. And this was the device which sometimes the patient was skipping to open the device. We create a pie chart which shows that this is the bad adherence and this is the good adherence. So this report we printed and we shared with the staff nurses, which they can use that during the feedback when they come for the clinic. So this is how we follow our patients. So like I said, we randomized them into 3 arms. One was control, the other one was SMS, and the red one is the RTMM. And once they've been randomized, for those who are in the control, we didn't providing anything, so we just follow the standard of care. For those who are in SMS, we wrote them in SMS reminder arm so that they can receive the reminder SMS half an hour before the intake and the follow-up question 1 hour after the intake, just to ask them if they take the medication or not. And for those who are in RTMM, meaning like they receive the device, and then again, the device sends the signal to us if it's open or not open. So in the visit 2, we produce so when they come for the visit, so we make sure that the report is there on time. So the staff nurse, they can have access to the report, and they use that report just to have the more interact discussion with the patients when they come for feedback. We are taking the sample for the viral test at the entry point of our study. And also after 57, also we check the viral test to see if there's any significance of the viral suppression. So this I've already mentioned. So our results. So we screened 265 participants. For those who were eligible, were 249. We randomized them for RTMM was 89, SMS was 86, and control was 88. So preliminary results show that 71 were women, and median age was 41. So up to September, when we came for the ICASA conference, 111 participants were finished in 67, 41 were in the RTMM arm, 36 were SMS arm, and 34 they were in the control arm. So what was their result? So at the entry point, like I mentioned before, we took the viral, and we saw that in the RTMM, for those who are below 20 copies mils were 42. And for those who were in SMS were 53, and for those who were in control were 50. After the intervention, for those who were in the RTMM arm, 71%, they had 20%, below 20% copies per mils. And for SMS, they were 64, and for control, they were in 67. We also looked for those who were above 400 mils, copies per mils, and we saw that in RTMM there was like 17, which is the lowest number compared to the rest of the arm. And also we looked for who were detectable and non-detectable. So at the entry point, we saw that we compared the entry point and after 48 weeks. So we saw that in RTMM it has like high significance because 63 of the participants they becoming undetectable, which is a good number. So in a conclusion, what we consider, of course, still this the study is ongoing. We are only half of the participants that finished the study, but we can see there's a good significance that RTMM could have high impact when it comes to the viral Oni suppression. But still, we are going to look for the rest of the group, which is planning to finish the study next year in February. So to acknowledgement, I'd like to acknowledge the staff team, Project BI, who is also here, Dr. Marion Sumari, our supervisor, our institution, our Ministry of Health, Tanzania, and our founder, who are IDB. And the last thing, I'd like to acknowledge ICASA for selecting this as the best abstract for this one. Thank you.
Thanks. Congratulations, Kennedy and team. We'll now have discussions. Please keep the questions precise and addressed to the panelists that you would want to answer a question. We'll start with the back. Can I have a microphone at the back?
It's Dr. Gonzalez from the Healthcare Foundation. Congratulations to all the presenters. I think this is the best session that I have already seen in ICASA. Okay, thank you so much. For the first presenter, my question is, you mentioned in the last slide that you developed tools, probably from the findings of these questionnaires or this survey that you did for the health practitioners. Did you measure the impact, let's say, of the implementation of these tools in the viral load cascade? This is the first question. The second, for the presenter of the project, yes. I see kind of a little bit shocking, really, the findings of the study about the lack of difference between the comparison group and the intervention group in terms of viral suppression. And then my question is, because you are comparing massive kind of support versus nothing in terms of the different type of peer mentor meetings, youth group meetings, different things, no? The thing is, did you look at really the content of these kind of meetings or the content of the peer mentors kind of meetings? I mean, what was given during these meetings and activities? I mean, which kind of content did you use? I mean, did you question that maybe, you were not giving the right message? I mean, there was something really in the in the meetings that was not the right kind of message to the adolescents? I don't know. I mean, if you really, after the study, did you think about this, no? And then for the...
Lastly,
sorry. For the fourth presenter, for Dr. Grace. My question is, all these pregnant women were newly diagnosed HIV positive immediately before kind of entering the study, or some of them have been known HIV for some time? Because the thing is it possible that any of these participants have taken ARVs before, and then they stopped taking ARVs, and then you did the viral load thinking that it was the baseline viral load, but in fact they have some history of ARV?
thank you. Let's take some more questions. Yes, please.
Thank you. I'm Daniel Momo from Zambia. I have a question for the first presenter and I think the third presenter. It's the same question. I would like to know from your experience and practice on the ground, how much session do you advise for enhanced adherence counseling before you repeat the viral load? I know it's within 3 to 6 months, but how often do you feel you need to see the patient? Do you have a standardized way of doing, or is a patient-centered approach where each patient is assigned a certain number of sessions? Thank you.
Okay, my name is Dr. Kambale from Eswatini. My question is to Kenneth. Did the device record only the opening of the device, or it's also recording if the peak was really big from the device?
Those are excellent questions. Let's have a response, and if there's time, we'll have another round of questions.
Thank you. I'll respond to your question whether these participants who were newly diagnosed or some had been diagnosed previously and were just initiating AD. Our primary interest was no prior exposure to HAD. So some of these had been in care, they were in pre-AD, they were on cotrimoxazole as reported by the participants, and they denied any history of a prior AD exposure. Thank you.
Excuse me, I'm losing my voice this week. I can respond to the, I think, first question. So the question was about not seeing a statistically significant difference between our study arms across all 4 of our clinics. So we definitely looked at the content of the peer mentoring meetings. They were very closely monitored. They covered a range of topics from adherence support to more general healthy living activities, information about nutrition, getting enough sleep, things like that that support adherence, as well as sexual and reproductive health information. I think that what we believe is happening basically is that, well, first of all, we did see a statistically significant increase in viral suppression in our pediatric setting, so I wouldn't say that we didn't see any changes. We also saw a statistically significant decrease in internalized stigma across all 4 clinics. So, but in regards to our non-significant differences between arms, one of the things I do think is primarily driving that is our uneven loss to follow-up. So, as I mentioned, there was more than twice as much loss to follow-up in our comparison arm, and we think that this is largely due to the fact that, of course, our intervention participants were being contacted on a very regular basis by peer mentors, and so remain more engaged in the study than some of our comparison arm participants. And as we know, young adults in general are often quite mobile at this age. Many of our, some of the folks who we did lose for follow-up, who we were able to identify and track, had left for school or had kind of changed phone numbers as happens. And so I hope that answers that question.
Thank you so much. I think the other question was looking at what was asking about the optimal number of adherence counseling sessions that patients need to receive for them to actually be virally suppressed. And you also we're trying to find out when this adherence counseling should be actually offered. Like in our study where we were looking at virological rebound, we had actually followed these patients for 24 months. And in those 24 months, we found that patients that had received more than at least five adherence counseling sessions were actually had a lower risk of experiencing virological rebound. So I think this finding actually provides a platform for further research, because I don't think we can say that the timing of when the adherence counseling should be done has been actually stipulated in any of the policies. However, patients opt to receive adherence counseling whenever they come to receive any health services at the clinic. So like in South Africa, as patients come to receive ART services, they are also offered adherence counseling, irrespective of the services that they would receive. But of note is that not all patients do receive the adherence counseling, possibly due to health worker resource sort of shortages, and also maybe the unavailability of adherence counseling counselors at clinics. Thank you.
Okay, thanks for the question. Concerning the first question, it's a very good question. We don't have an evaluation of this tool. This tool was developed at the end of the project, and the project is now finished, and we would like to perform it this year in another project. But of course, it's a very important question. And especially, I maybe not mention that we also develop some kind of explanation of the algorithm to make them more easy to use, and we would like to know if it works in the real life. So, good question. And concerning the second question, concerning the number of adherence counseling, with this project, we have data from Virological database, so we don't have the number of adherence counseling sessions performed in the patient. So I cannot give result from this result. In the field, we see a very huge variation. It depends of the country, it depends of the sites, and it really depends of human resources. And in some places, it's just not possible to have adherence counseling, even of course if it's written in all the guidelines. And I can say that the usual number required is 3, but really 3 adherence sessions. But really, we don't have a clear evaluation of which number is required. And the second point is the number is easy to monitor. What about the quality?
Okay, so I'll respond to the question that if the device recording somebody take the medication or not. Yeah, so that's a good question actually. For the time being, what we are trying to see, first of all, is the feasibility of the device. First, if it can work in the limited resources. Because we got the device from the West Coast, South Africa. It have never been used and explored to especially in the part of Tanzania. So this is like the first time we're doing it in a clinical trial. But the question if the device recording, can able to see if somebody take medication or not. So far, we only depend on the opening of the device. So we can able to trigger that the person has opened the device by notifying the time that the device was open and the signal which comes to our server. However, we're also checking the viral load. So which at least we can able to see that if there's any suppression of the viral load. But on the future studies, we look at that if we can help also doing kind of PK studies just to see if there's any concentration of the drugs in blood. So that's why also we are looking in the future. But for the time being, the device is recording the time of intake. However, the question is if somebody has taken the medication or not, we only depend on the viral load suppression. Thank you.
Thank you so much. Any other questions?
Good morning. My name is Oni Idigbe from Sierra Leone. I thank you for the presentation, and I know it's country specific. I want to know if the package you use to monitor the patients whose viral loads were suppressed really involves any kind of support that helps people living with HIV to really attain viral suppression within the period you have given. I listened. I just thought of my country. I'm coming from West Africa, and to let us reach or attain the type of results we are talking about, I think it must involve greater support, most especially nutritional support for people living with HIV. But for my country, it's quite a difference. And if we are all to fight together, I want to appeal that it should not only be focused on these improved countries, but you look back to us, majority of us are living with HIV, children are suffering, no proper nutrition for even the mother, and so I wonder how the viral load can be suppressed. For me, I am not the mathematician, I'm not the doctor, but the woman living with HIV and their coordinator. We are suffering from that, and so I want to appeal that to attain viral suppression, the whole package must cut across every nation. I appeal.
Yes, please.
Morning, everybody. I'm Antiretroviral from Nigeria. I was hearing, my question is to the fourth speaker. I heard a few things, a few terminologies, pre-art, art, and option B+. And I wondered, is that we haven't started test and treat in your place yet? Because it shouldn't apply anymore if test and treat is being practiced at the moment. And then, I don't know if I understood properly, but it sounded like you took the samples to check the virological suppression after 4 days of art. I mean, people have been on drugs for just about 4 days before you took samples for check viral load. So I don't know if my understanding is correct. Did you actually expect that virological suppression would have taken place, full virological suppression would have taken place in just 4 days? I think we did resample a bit too early. That's actually my question. And then you also talked about what was that? Sorry, it's okay.
Thank you. At the back.
Hello, thank you to everyone for a great session. Nathan Ford at WHO Geneva. My question's for the first presenter, but it can also be for others. And it's to wonder about your thinking on how the algorithm might need to change when dolutegravir is introduced in first line, because until recently there's been a consideration of simplifying the algorithm by switching more rapidly. But with dolutegravir coming in, some countries are considering to be much more conservative about switching and to focus more on adherence than considering drug resistance being the reason for high viral load. I hope my question is clear.
Thank you. Let's have the final response to the questions before we close.
Thank you. I'll start off with you had questions about pre-ad and test and treat. As a country, we are now implementing test and treat. This study we started implementing enrolling participants in 2016. However, our inclusion criteria was pregnant women who are initiating HAD. If you look back, I think we've had different options for PMTCT. From option A, where we would not have highly active antiretroviral therapy. So in such cases, from way back, I think we are all aware, initiation of ART was dependent on CD4 count. So when we had such participants coming on, but they have not been on triple therapy, these were eligible for study enrollment. So that's why I say it wasn't people who are newly testing, but these could have, some of these were participants who had already been living with HIV but had not been enrolled on ART since the country back then hadn't started test and treat. Your second question is about viral load suppression. As a program under Ministry of Health, our first viral load is done at 6 months after initiation of ART. However, as a study, we were interested in knowing what is the baseline viral load of these participants. So we did viral load at study enrollment. Not that we expected that the viral load should be suppressed, but rather we wanted to know where are we starting from. And so when I talk about the median of the 4 days, it's not that I expect anything, but I needed to relate this to someone has been on 4 days of ART, but what's the expectation? How long should you be on ART before your viral load is suppressed? So if at initiation you're already suppressed, I'm seeing 0 copies per mil, I'm seeing perhaps 0 to 19 copies per mil, then it raises questions. How am I going to monitor this person? If you're at 0 at the start, how am I going to use viral load going forward to show that you're adhering? If you're analyte controller, I know you, even if you didn't take your meds, you're probably going to remain unsuppressed over a long time. So viral load monitoring may not be feasible in estimating adherence and efficacy of the regimen that you have been given. I hope that's clear.
Concerning the very good question about algorithm, your question was very clear. For the answer, it's more difficult. I think just concerning this first presentation, I think the message is we have to be careful with the algorithm. Because when we see for the first time this algorithm for viral load, it seems very easy. But in the real life, it's more complex than anticipated. So I think we have to bear it in mind when developing new algorithm to say how can it be feasible in the field. Concerning dolutegravir, yes, it's true that the higher genetic barrier in comparison with NRTI is of course a good option, and it's probably the same that in the second line with boosted PI. We know that it's possible with people with high viral load, with adherence counseling, to have viral suppression. But I think today it's very difficult because we're just beginning the implementation of dolutegravir, and there is, I think, a huge challenge concerning the emergence of drug resistance, because you know that many patients are now treated by NRTI, they don't access to viral load, and they are going to be changed to dolutegravir, and some of them, many of them, will have drug resistance mutation to tenofovir, to zizabine, and so on. So really, I think we need more study, and it's really difficult now to take a decision. Thank you.
Thank you so much. I think let's give our panelists a big hand clap. And thank you all for the questions. So our key take-home points today were we need to really engage healthcare workers and train them in how to switch, but also address the perceptions they might have towards switching to second or third line. And much as we saw that peer support did not have an impact on viral load suppression among adults, it was important in the children, but also among the adults there was a significant improvement in self-stigma, which may ultimately have improved outcomes for the people living with HIV. And enhanced adherence counseling, improved immunological status among people living with HIV is important. And we need to embrace mHealth and technology monitoring medication, as well as monitoring women that are on ART for viral load response. And it will be interesting to do more studies among the elite a bit controlled as you assume. So thank you so much. This comes to the end of the session. Have a good night.